Okay. Okay. So my name is Daniel Stone. I'm one of the doctors working with KOPI to do some community medicine outreach. Today we're going to talk about altered mental status, okay? Um, this is a topic that you guys have expressed interest in. It's extremely broad though, so we're going to kind of try to hit the basic approach to the acute care approach to altered mental status. So we're going to talk a little bit about definitions, specific entities that can cause altered mental status, and kind of a general review. So first, a case, elderly female presents to the casualty. She's been less active, eating less. She's been more encephalopathic and altered. Her son, who's concerned about her, said that, she developed shortness of breath or maybe some shallow breathing earlier today. He's not concerned if or he is concerned that she may be in pain as well. She's tachycardic, hypothermic, and tachypneic. This is an actual case that I'm sure you guys see regularly. She doesn't have any focal deficits, but she is disoriented. So hopefully you can kind of picture in your mind and create a little mental image about what you'd be concerned about, what you might do next, um, in the setting of kind of this finding, what you would specifically examine. Um, so we want to discuss the initial approach, which is basically kind of what we're already alluding to is what would you do in the circumstance where you have the specific patient in front of you. We want to talk a little bit about definitions because definitions are important. Things categorized in altered mental status, kind of unlike in other conditions. We're going to talk a lot about delirium and encephalopathy, the differences between the two, but also the possible causes of delirium and encephalopathy. We're also going to talk a little bit about stroke, but we're not going to have a comprehensive lecture about stroke because that's a humongous topic in itself. Um, we're going to talk a little bit about CNS dysfunction and how it also relates to altered mental status, the specific entities that can cause CNS disruption, and talk a little bit more about treatment as well. Um, Again, this is a very, very broad topic. Altered mental status is something that you guys expressed interest in, so that's where we're kind of starting a topic, and I hope it facilitates some discussion in terms of what we can talk about as a more narrow view of altered mental status. Um, Altered mental status is basically just defined as a deviation of any baseline mental status. So individuals have different baseline mental statuses. Not everybody's a walking, talking doctor. There's not really anything that necessarily constitutes a finding of altered mental status, but there are some definitions um, within itself in terms of different types of altered mental status. Um, the causes are almost always differentiated clinically. And the reason why is because, there are things like CTs and MRIs that can have findings, but you need to actually, as the clinician, determine what is the primary finding in terms of what's causing the deviation. Usually, the standard workup includes a CT scan or MRI of the brain, basic blood work, an EKG, usually work up for infection if clinically indicated. But the most important thing is usually a medication history. So basically, assuming that you've talked to the patient, you've talked to any collateral information, you make sure to actually discuss with family, with any collateral individuals that may have prompted the patient's presentation, um, and make sure that you corroborate whatever history might be obtained from the patient, from the family, and making sure that you've put all the pieces together in order to try to come up and form a differential. Um, so when you're examining somebody who's altered, if they roll in, we'll talk a little bit about kind of a general approach, but the most important component to an examination is probably a neurological exam. Cranial nerves are important. Working your way down, it's usually the first part of a neurological exam. I often look into people's pupils to try to kind of yield any dilation, any constriction, because it can have a lot of insight in terms of what might be at play in terms of toxicologic causes or drug causes. Um, Visual field cuts are also generally important. Nystagmus can also be seen, so it's important to do a thorough cranial nerve examination. Um, you also want to make sure that you examine the patient's mental status, and we'll talk a little bit about this in the next slide, but mental status basically yields a whole differential in terms of what the patient is not able to do. You want to make sure that you do a motor exam to evaluate for any weakness, any deficits that may yield concerns for stroke, intracranial hemorrhage. So you want to assess the patient's strength. You want to do a reflexes exam. Make sure that you're comfortable doing these types of exams. There are plenty of ways to evaluate strength, basically grip strength, pronator drift. You want to assess major muscle groups, make sure that you have them move their toes, move their hips. And we can talk a little bit about this. A neurological exam it can be a complicated thing to get into, but there are lots of different ways to do it. In lots of different ways. I have different derivations of a motor exam, depending on what I'm concerned about. Um, you also want to make sure that you assess their coordination and their gait. This is actually generally pretty important. There are a lot of different types of encephalopathy that are associated with ataxia. And performing basic tasks also shows the patient's ability to act independently. The ability to basically perform basic tasks, coordinate movement is something that's kind of essentially human. And if they can't do this for whatever reason, it kind of fragments and creates risk in terms of their actual altered state. In regards to a mental status exam, usually this isn't necessarily a dynamic exam, it's a conversation. You want to make sure that you're actually doing these three things, which is just basically assessing the patient's orientation, their attention, and then assessing their level of consciousness. Now, this isn't a true mental status exam. A mental status exam is usually done by a psychiatrist or a neurologist and can be pretty comprehensive. From an acute care standpoint, I want you to remember orientation, attention, and level of consciousness is kind of the general vibe and the general approach to what a mental status is. There are 4 degrees of orientation: person, place, time, and situation. So when people describe that they are oriented times 4, they can answer all of these 4 questions, and they can demonstrate some understanding about their orientation in regards to these questions. Attention is a pretty broad thing, but it usually is deviated in delirium or dementia. Attention basically just assumes that an individual is able to perform basic tasks. So usually in the United States, what we ask patients to do is we ask them to count backwards from 20 by threes, or we ask them to spell a world backwards. These are just simple tasks that any individual who has a basic education should be able to do. If they don't have a basic education, attention can be kind of difficult to assess. But usually just asking an individual to try to remember 3 basic objects or words throughout the interview is also a decent way to assess attention. Level of consciousness is generally something that is defined by clinical findings. Now, there are different types of alterations of consciousness. These are definitions and not necessarily something that I would take for, you know, anything beyond what we use the words for. So, encephalopathy, delirium, coma, stupor, stroke, and dementia are all terms that describe alterations of consciousness. There are many other different definitions, but those are kind of the general ones that I want you to remember. Encephalopathy is just basically brain dysfunction. It can lead to decreased level of consciousness, and it can occur in the setting of global or focal insults. This is probably the most common reason for altered mental status. Encephalopathy basically assumes that there is an underlying insult to the brain. Um, Delirium is different, though. Delirium is usually implied as a toxic metabolic encephalopathy, but it usually implies that there's impaired consciousness, or more importantly, impaired attention, in the setting of an aroused cortex. So basically, what that means is that it means that somebody has encephalopathy, but they don't necessarily have any depression of their cortical higher functioning, meaning that they're disoriented and they're inattentive, but they don't necessarily have any other focal findings that are acute. This means that they usually have some underlying infection or medical condition, medication or toxin in their system that's actually contributing to this condition. Delirium is a very specific type of encephalopathy. It doesn't necessarily have to exist isolated from encephalopathy, but usually delirium is a clinical definition that implies that they have some medical etiology that's contributing to their inattention or disorientation, and that they have either of those two findings in isolation of any other focal findings that might prompt the consideration of other encephalopathies. When somebody's talking about coma, they are talking about an unarousable, unresponsive state. This basically means that if you sternal rub somebody who's in a coma, they won't necessarily respond. Usually presumes that the patient does not have any cognitive function, does not have any sleep or wake cycle, and is usually some degree of bradypneic or apneic. This usually happens in most severe forms of brain insults, or kind of the most severe forms of encephalopathy. Stupor is basically unresponsiveness, but a patient can be aroused. Um, Stupor is usually what we see with toxic encephalopathies, intoxication. And stupor implies that the patient does have some degree of hemodynamic compensation, and or respiratory compensation, and they're not necessarily apneic or bradypneic. Uh, so stroke is its own definition as well. Stroke implies that there is acute brain ischemia, or a vascular etiology um, that's causing a brain insult. Stroke can absolutely cause encephalopathy, and I want you to remember that encephalopathy is a general term. If you don't know why a patient is altered, and they don't necessarily have clinical findings suggestive of stupor or coma, then it's not unfair to call them encephalopathy, but you want to make sure that you try to identify why they may be encephalopathic. Stroke's a very common cause, and it's why we do CT scans. We'll talk about stroke a little bit differently. Dementia, lastly, is a progressive and usually chronic neurological decline, and it usually causes non-focal deficits, but does cause inattention and disorientation. It's extremely common in the United States. It can be difficult to determine chronicity sometimes due to baseline deficits. When you're talking about altered mental status, usually the clinical presentation is similar to the case that I presented earlier, where an elderly patient from Tanzania presents. Um, if you're talking a little bit about, how to differentiate dementia from delirium, it can be extremely difficult, but usually it has to come down to historical factors. So knowing a lot about your patient, knowing their past medical history, knowing their past medical conditions, their hospitalizations, is extremely important. And it's also always important to remember that, any and all of these conditions can coexist. Dementia patients can have strokes. You can have stupor, but not coma, in the setting of encephalopathy. Encephalopathy is a type of delirium. These are all just definitions. They're not necessarily meant to imply that, this creates a differential for you, but when you use words, you just need to know what they mean. Um, okay. So neurological findings, basically any deficit that is appreciated on exam implies that there can be, you know, any deviation from a baseline neurological function. So a deficit is basically what you're searching for when you're trying to evaluate somebody with altered mental status. They can be chronic, they can be acute. They should be interrogated based off of your clinical concern from exam. So anybody who's elderly, who's altered, should have a cranial nerve motor exam because you want to make sure that you don't notice any findings that would prompt a consideration for stroke. Um, you're searching for deficits. When you do an exam, you want to try to evaluate each individual part of the neurological exam, the cranial nerves, the motor function, the coordination, and then the mental status, each individually trying to evaluate for a specific deficit. If a deficit is appreciated, then it changes your differential and it may change the test that you order, or it may potentially change the findings and things that you're doing for the patient. Um, the most important component to alter mental status that I want you to try to remember, and again, this is not a comprehensive discussion regarding neurological examination, but there are findings on exam that are called negative symptoms and positive symptoms. Positive symptoms basically imply the presence of abnormal neurological phenomena. This means that they have tremor, they have spasticity, they have tonic-clonic movement. They have involuntary movements. They have hyperreflexia. They have asterixis. They have findings that basically implies that they're moving when they shouldn't be. Or, basically neurological stimulation is what that means. Positive symptoms come usually from toxicologic disorders, metabolic disorders, hyperactive disorders of the brain. So things like seizures. That's basically implied. When you talk about negative symptoms implies that there's a loss in neurological function. So this usually implies something like weakness, paresthesia, sensory loss, hyperreflexia, inattentiveness, things like that. Those are negative symptoms, and those are usually implied with some degree of stroke or central nervous system pathology, vascular pathology. Now, negative and positive symptoms doesn't necessarily appreciate coordination. That's usually an evaluation of motor function and mental status. When you talk a little bit more about coordination, you talk a little bit about ataxia and dysmetria. Now, these are basically inability to perform basic coordination movements. Ataxia implies that you're unable to perform voluntary movements. And dysmetria basically means that you're unable to provide goal-directed movements. Now, what this means is that ataxia implies you're unable to basically walk or do activities of daily living. If somebody's not able to sip on a cup of tea or chai or use a spoon to, eat, then that implies that they're unable to perform voluntary movements and that they're ataxic. Dysmetria is basically a clinical examination, meaning that you evaluate an individual's ability to do finger to nose or heel to shin, and they can't do it. So slight differences there, but basically both are assuming that there's some degree of discoordination that the patient isn't able to perform. So those are findings that you see on neurological exam. Um, just to reiterate, you want to try to examine the patient as comprehensively as you can. The neurological exam is the most important part of the exam. However, it's not everything. Um, we want to talk a little bit about types of encephalopathies as they relate to kind of your general approach when you're approaching these patients. Um, that encephalopathies are kind of the most important, um, you know, causes and potential. They're uh, the most common reasons for individuals to have a deviation in their baseline mental status. There are three general basic ones. Um, in all honesty, this probably should be. I'm going to come back to this slide, okay? So the general approach to approaching a patient with altered mental status. Um, Generally, I look at the vitals first. I want to make sure that there aren't any vital sign abnormalities. If a patient has a vital sign abnormality and they're altered, then that usually means that the underlying vital sign abnormality may be causing their altered mental status or should yield a little bit of differential. This is, in all honesty, 90% of the approach. You want to make sure that the vital signs are kind of interpreted in the setting of what's potentially going on with this patient. Altered mental status is a form of end organ damage. And so if you see a patient who has undifferentiated altered mental status, it's immediately a clinical finding that suggests that there's potentially an emergent process at play. Um, when you evaluate these patients, usually you want to kind of take it step by step and make sure that you actually focus on a primary survey first, focusing on airway, breathing, and circulation, and making sure that you actually assess these individual things first. A patient who has significant significant deviation in their mental status and can't control their airway is a patient who I'm immediately concerned about and want to stay at the bedside with. Um, Breathing is an important vital sign, and obviously the respiratory state of the patient will also control what you do next. You want to make sure that you're actually assessing the patient's breathing to yield some degree of focus in terms of what needs to be ordered, how concerned you need to be, and whether or not they need any degree of respiratory support. Circulation is also an important thing and kind of yields a little bit more importance in terms of vital signs. And then the most important bedside test that want you guys to always remember, and hopefully you do, is to always remember to use a glucometer to evaluate the patient's glucose. Hypoglycemia is a common cause of altered mental status. So is hyperglycemia. And glucose level is always really, really important. Um, we'll talk a little bit about that later, but obviously, glucometers are generally pretty easy to find in most casualty departments. Most nurses know how to use them. So just make sure that you remember glucose as part of the primary survey. Um, when you evaluate these patients, the secondary survey is really looking for kind of big things. I don't do extensive examinations outside of the neurological examination for these patients. In the setting of any trauma, I want to make sure I evaluate their head. I want to make sure that I look at their tongue to evaluate their hydration status, but also to look for any tongue lacerations. Tongue lacerations are usually very commonly associated with seizures. I, want to listen to their heart specifically for rate. I want to watch their breathing, specifically looking for any tachypnea or bradypnea, kind of implying that, you're already doing this as part of your primary survey. I want to feel on the abdomen, making sure that it's not rigid or peritonitic. And then I will always try to expose these patients. I know that it's a little bit harder in Tanzanian culture to get patients to go into gowns, but in the United States, we commonly put these patients into gowns so that I can look at their back, so that I can look at their skin, make sure that I kind of see, what's going on. If patients have skin breakdown over their back or over their buttock, or they're incontinent, it's implying some degree of chronicity to their altered mental status. And it means that they're not necessarily taking very good care of themselves over a period of days. And that is really important information. We'll talk a little bit more about kind of what the historical features are in altered mental status, but Um, we care about um, we care about chronicity. So, um, the historical features that matter, we talked a little bit about exam. I'm sorry I did this a little bit backwards. I meant to put history a little bit earlier. I apologize. But in terms of the historical factors that matter, when you're evaluating a patient who is altered, you want to make sure that you have a good understanding about what historical factors are at play, how long this has been going on, the duration, the onset too. So sudden versus gradual onset is a very important historical factor when you're talking about evaluating a patient with altered mental status, because you want to make sure that you're kind of forming your differential based off of, they were fine and now they're not fine. Um, a sudden onset yields kind of a really strong concern for stroke or seizure, or possibly that they had gotten into something, that they tried a drug, or that they mismanaged some of their medications. So, tox is certainly also on the list as things that can cause sudden onset of altered mental status. Gradual onset more is, I think more toxic and metabolic as well as infectious. The presence of trauma is also always really important, for obvious reasons. Trauma dictates care if it's present. You want to make sure that if you're evaluating somebody, that you're asking the family member, the bystander, anybody, about infectious symptoms. You also want to make sure that you understand if they have any new medications, if they're taking any herbal supplements. These things can commonly cause toxicological manifestations. I know in Arusha there are a lot of herbs that people tend to use, and that those can also be kind of on the differential for the toxic encephalopathies. So just making sure that you ask about those. Um, also making sure that you review their med list if they have medications that they're using, and that you also, watch them take their medications. If you're concerned about them potentially mismanaging their medications, or if you're concerned about potential side effects. Usually patients who are confused or altered or encephalopathic get admitted to the hospital. So usually this is an option in terms of trying to manage patients long term, is trying to control their own medications and see how they take their medications, making sure that they don't necessarily take them inappropriately. Um, Dehydration is also a common thing that causes morbidity, mortality, in patients who are encephalopathic, not necessarily as kind of a cause, but usually if they are gradually encephalopathic, it's important to remember that they're not eating and drinking, so that they probably come to you in a dehydrated state. Um, so this is a little bit more of a reiteration of what I already said. But it's important to talk about their drugs and their medications, mostly because things classify into different drug classes. And you want to make sure that you assess that they don't have any of these drug classes on their medication list. In the United States, elderly patients are commonly prescribed, medications like sedative hypnotics, medications that can stimulate the central nervous system. Hallucinogenics are usually used more recreationally, but can certainly be something that can also, be a manifestation of over-the-counter or prescribed drugs. Specifically, steroids is the one that causes kind of hallucinogenic or dopaminergic, serotonergic effects. Um, you also want to make sure that you assess their medication list for anything that's anticholinergic. Anticholinergic medications are extremely common. They include a vast array of medications, but it's a common reason for patients to become delirious is initiation of an anticholinergic medication. If you're ever concerned about a medication and its potential propensity to cause anticholinergic effects, you can look it up. There are a lot of medications that can cause anticholinergic side effects. Alcohol use is also a really common thing that has its own different differential in terms of what can cause altered mental status. Make sure that you're asking your patients about this. I don't always ask all my altered mental status patients about drugs or recreational use. I'm always making sure that I ask them about medications, and I'm always asking them about alcohol as well. So make sure that you ask about alcohol. And make sure that, regardless of how well the patient is able to provide any history, that you're always pursuing collateral information. The reason why is because collateral information yields more information than you would otherwise get from the patient, always, always, always when they're altered, because that's why they're there. So if you feel like you're not understanding exactly what's going on in terms of the patient's presentation and what might be at play, I want you to make sure that you're always asking bystanders, family, friends, any individuals who are living with the patient, kind of what all is going on, and making sure that you have a good understanding about what actually happened before this patient became altered. Um, Again, I apologize that history was a little bit cattywampus um, in the in the presentation. So vital signs, when you're kind of going back to how to evaluate the patient, vital signs is kind of like the first component to it. And when you're assessing the vital signs, I want you to kind of remember, this is just a list. It's not necessarily super as comprehensive, but it's important to remember that any vital sign abnormalities, when present, can yield kind of a differential. So if a patient's tachycardic, the first thing that comes to mind is infection, but you can also see tachycardic patients from metabolic dehydration, tox. Bradycardia usually makes me concerned a little bit more about like sedative hypnotics, tox, medications, or possibly intracranial hemorrhage as part of Cushing's triad. Hypotension usually makes me think of infection. It can also make me think of hypovolemia in terms of that's driving the altered mental status. Um, Hypertension also raises a different differential. Depending on how severe it is, it could be press, it could be kind of a form of hypertensive emergency, but it also makes me think of intracranial hemorrhage. Um, if you see patients who, are normotensive, but they have a narrow pulse pressure, i.e. their blood pressure is, 100 over 80, I want you to think a little bit more about dehydration, possibly hypovolemia, if the clinical picture fits, bleeding. Um, Hyperthermia also makes you think of infection, makes you think of toxic etiologies. Hypothermia also kind of adds the same type of differential, but remember that that can also be seen in endocrinologic disorders. If someone comes in profoundly hypothermic and altered, I also want you to make sure that you're understanding that they could be altered because of their hypothermia. Severe hypothermia manifests as altered mental status. So make sure that you're warming those patients, putting warm blankets on them, or removing any wet clothing. Um, Hypoxia can also certainly cause altered mental status and is certainly in the differential in terms of causes. So if you see a patient who is hypoxic, try to correct their hypoxia before you assume that it's not necessarily causing their altered mental status. But make sure that you're working up their hypoxia um, as well as their ultimate mental status. Breathing patterns are also kind of an important one. There's some nuance to this. So if a patient is tachypnic, I want you to kind of think that, they may be acidotic. Make sure that when you order a BMP or a VBG that you're looking at their bicarb, you're looking at their pH, you're trying to actually evaluate a little bit about their metabolic status. And the reason why is because acidosis is treated a little bit differently if it's causing altered mental status. And we'll talk a little bit about that in kind of airway management. But um, acidosis is commonly uh, associated with severe metabolic derangements. It's associated with renal dysfunction, DKA. There's a lot of different things that can cause acidosis. But if you see a patient who's tachypnic and altered, I want you to kind of presume that there's some degree of acidosis at play. We'll talk a little bit more about that. Bradypnea, this is kind of assumed, but we see a lot of opioid ingestions in the United States. Sedative hypnotic use is also something that kind of comes to mind when you see somebody who's has shallow breathing pattern. Um, and is altered. Bradypnea is also a component to Cushing's triad, so think about central etiology. So coming back, when we talk a little bit about, all these findings, the vital sign abnormalities, we're talking a little bit about, ruling in or ruling out a disorder. Encephalopathies are by far the most common reason for patients to present with altered mental status. Um, Types of encephalopathies include toxoplasmic, metabolic, and septic. Toxic encephalopathy usually assumes that there's some degree of delirium, but again, delirium is kind of its own diagnosis. Um, but an encephalopathy is usually at play if you have basically decreased level of consciousness with no focal findings, basically. Um, and that's usually the cause of delirium. Delirium specifically has the inattentiveness, though, built into the diagnosis. So when you talk about kind of you know, all these different differentials that are formed based off the vital sign abnormalities. They're not necessarily changing management, but you want to make sure that you address and identify why the patient is altered, because that will change management moving forward. The acute care component to altered mental status that I want you to take away from is that, these patients should generally be watched in the hospital. And their observation in the hospital will kind of hopefully yield the diagnosis. And you want to treat all vital sign abnormalities. Those are kind of the two things that I want you to take away from this lecture. Is that the vital signs are vital. And if you see any vital sign abnormalities that are present when the patient comes in, I want you to kind of try to ask yourself, they're tachycardic. Why are they tachycardic? What can I do to correct their tachycardia? Things like that. Um, Imaging plays a role in altered mental status. I want you guys to not fall back on it, but usually CTs of the head are recommended just to evaluate for stroke. It's not very sensitive for acute stroke. So if a patient presents with just kind of acute deviation in their altered mental status, know that you're really just looking for blood at that point, but you won't necessarily see any um, large blood vessel occlusions or any like substantial amounts of ischemic stroke. And that's just because CT scans aren't the best for that. If you do an angiography study, you will be able to see the vessels, but it's not necessarily something that I expect everybody's doing in casualty departments in Tanzania. Usually MRIs are also recommended, but I don't want you to necessarily feel like you need to fall back on an MRI. I would say that MRIs can see reasons for patients to have encephalopathy, but it's not necessarily anything that I want you to feel like you have to do if you're watching these patients in the hospital. Probably the most important component to the workup is laboratory studies. Again, history and physical is where all the 90% of the information should come from the history and physical, but if you need to fall back on any type of test, laboratory studies are usually the ones that are the most important. And usually this is going to yield some information. The most important is glucose, just because we can so easily do it at the bedside. Make sure that you get a glucose immediately after you're evaluating the patient's altered mental status. The airway, breathing, circulation, glucose. Those are like A, B, C, D, G. Um, CBCs are generally not very helpful. I know that every patient gets a CBC, but it's generally not necessarily very helpful. Most types of encephalopathy are associated with leukocytosis. BMPs are probably the most helpful, just to evaluate the patient's acidosis, their sodium, and also make sure that you evaluate their renal function, mostly just because these things can cause some degrees of encephalopathy. I know that we're not necessarily getting these regularly, but VBGs are also really important. I want you to try to push your hospital leadership to try to get a blood gas analyzer. Um, blood gases are important and interpretation is complicated, but if you get a VBG, just know that the pH is a very important value, and so is the CO2. Um, it usually just yields some information in regards to, whether or not the patient has a metabolic acidosis at play. And the reason why that metabolic acidosis is important is because if the patient's tachypnic and altered, your indication is to be like, oh, wow, they're really short of breath or they're breathless. Patients can be metabolically acidotic and be tachypnic, and you want to leave them that way, usually, because they're breathing to try to maintain their pH and they're trying to get rid of carbon dioxide. So a common mistake that we see in acute care is that people commonly intubate this patient, and if they do, they're not able to compensate. Their minute ventilation will go down, and they won't be able to compensate anymore, and they usually die if you intubate them. Um, Lactic acid is also a very important screening test. I commonly get lactates if I'm concerned specifically for seizures. Um, the other electrolytes that you can order separately outside of the BMP includes calcium, magnesium, phosphorus, because these can also commonly be associated with conditions that can cause altered mental status. Urinalysis is commonly ordered if you're concerned for infection. Ammonia evaluates for hepatic encephalopathy. I commonly get an alcohol level if I'm concerned that the patient has a concomitant disorder, or if I'm concerned specifically that they're withdrawing, and then get a pregnancy test if you're concerned about eclampsia or preeclampsia. So, if you're concerned about cardiac or central causes for the patient's altered mental status, I want you to remember that EKGs and EEGs are kind of commonly used as part of the standard of care. It's this isn't something that I would expect to be very regularly available in Tanzania, but it is part of the neurological evaluation, both for seizures and for different undifferentiated altered mental status. EKGs are also commonly used just to evaluate, tachycardia as the patient in sinus rhythm, but also for toxicologic etiologies. And then also remember that lumbar puncture should be reserved for patients who you're concerned specifically about meningitis and encephalitis. Um, there are other reasons to do it. You can evaluate for a myriad of other conditions, but those aren't necessarily conditions that I would expect you to be able to test for in Tanzania, unless the testing is available. Specifically concerns if, the patient had recent travel to Dar es Salaam, or the coastal places where malaria is more endemic. Um, so, in regards to strokes, I want you to remember that there are a lot of different types of strokes. This isn't necessarily a lecture on strokes, but there are several different types of strokes that can occur at different areas of the brainstem. Um, Cortical strokes are very complicated, but can occur, at the MCA, PCA distribution. Those are probably the most common. Internal capsular strokes also cause weakness, and can commonly be kind of concerning initially for brainstem strokes. There are cerebellar strokes that cause discoordination. Um, there are also other posterior types of stroke syndromes. Um, and usually strokes cause negative symptoms. So that's the big takeaway, is that if you have a patient who has clonus or asterixis, or any other type of positive neurological findings, um, usually your concern that there may be something toxicologic or metabolic going on should be higher than stroke. It doesn't necessarily mean that they can't have had a stroke. Any type of altered mental status can have multiple things at play. But the concern when you see somebody with negative symptoms, i.e., motor dysfunction, sensory loss, should be for stroke. There are so many different causes of metabolic derangements that can cause altered mental status. Remember that hypoglycemia can cause it. Hyperglycemia can cause hyperosmolar hypoglycemic state. So any glucose over 35 can cause altered mental status. Hyponatremia can cause altered mental status. Carbon dioxide retention can cause altered mental status. Uremia can cause altered mental status. Hypercalcemia, hypomagnesemia. All these things can cause altered mental status. So just remember that there is blood work to be done on most of these patients. Altered mental status is not something that you necessarily see and then defer a workup on. If there was one test that I would probably want on a patient who is altered, it would probably be a BMP or a basic metabolic panel. Um, you know, Infection usually implies that a patient has vital sign abnormalities that may be at play in addition to their altered mental status. Um, any patient who has altered mental status and infection implies that they have severe sepsis and even septic shock if they have hypotension associated with it. Usually this implies that you want to just try to correct the vital sign abnormalities. So you want to hydrate, you want to give some antipyretics, you want to make sure that you give them supplemental oxygen if they're tachypnic or if they're hypoxic. Um, and just remember that, infection is a very, very common cause of altered mental status. But a patient should have vital sign abnormalities, i.e., they should have SIRS if they're presenting with altered mental status from an infection. Don't necessarily hang your hat on an infection if the patient doesn't have any of these at play, um, because it doesn't it doesn't usually happen that way. It can happen that way, and infection should be considered in most patients, in all patients who are altered, but it doesn't necessarily mean that they don't have um, that they have normal vital signs. Usually they'll have some vital sign abnormalities that'll kind of cue you into infection. Um, so tox causes of altered mental status, again, a lot of different things going on. Just remember the big thing from this slide is that withdrawal is a reason why patients can be altered in the setting of toxicologic agents. Usually, withdrawal lasts longer than an intoxicant period. For example, alcohol causes confusion, and slurred speech, ataxia, but it usually only causes these symptoms for 8 to 12 hours. A symptom in alcohol withdrawal syndrome can cause symptoms for 72 to 96 hours. Um, I'm sure that I don't need to necessarily list all the potential signs and symptoms of each intoxicant and withdrawal, but just know that withdrawal can last longer than an intoxicant period. And just also remember all the symptoms of anticholinergic tox. One of the things that I learned, training in emergency medicine, but also kind of reviewing stuff for this lecture is that the most common finding is actually just dry skin. So dry mucous membranes and flushed skin without sweating is the most common clinical finding. It's usually present in about 75% of patients who have anticholinergic tox. So there are also a bunch of other central causes of altered mental status. This comes back to the lumbar puncture component to the workup, meningitis, there's autoimmune disorders, there are pure neoplastic things. Probably the most common thing is seizure that you guys see in Tanzania, postictal state. Usually it's associated with tongue biting, incontinence. The postictal state also has kind of clinical manifestations that we could talk about in a separate lecture that can kind of easily be picked up on. If you see enough of them, usually you can kind of tee them out as a possible mimic for encephalopathy or stupor. Usually postictal states get better unless the patient has continuous seizures. This is also why we observe patients. And you want to make sure that, seizures are treated separately, but that they get phenytoin or levetiracetam or whatever you have available to treat the seizures if they're at play. So, um, this is a really comprehensive topic, guys. So when you ask me to kind of cover altered mental status, it probably yields more questions than it answers. The brain's an extremely complex organ. Just remember that if you find one thing, you shouldn't necessarily stop looking for other things, but you should be asking yourself kind of what the pretest probability of those other things is possible at play, and whether or not if you found a clinical finding that concerns you, whether or not the clinical finding is the primary insult to the brain. Um, and that's kind of the most important question. Um, it's why I'm harping that the physical uh, and the history and physical exam is so important. It's because, just the clinical findings, the patient's presentation is kind of the most important part of why they're there. And if, they are there, then what what brought them in? What is at play at the very moment that you're evaluating them? Oh man. So in regards to airway, when we talk a little bit about like intubating patients like this, um, you know, my wife Cassidy, who works mostly with the pediatric patient population, wanted to emphasize that, patients usually with a GCS of less than 8, um, this, GCS less than 8 intubate, that comes from trauma data. And the only time that I would recommend that you guys extrapolate that is if the patient's having an acute stroke. So if you have findings on a CT scan that suggest an ischemic or hemorrhagic stroke and you're concerned about them, you may want to intubate them if they have a GCS less than 8. But a GCS less than 8 does not imply intubation for all other types of encephalopathy, stupor, or, any other altered mental status. The one thing that I do want you to remember that if they don't have the ability to protect their airway, and they have refractory hypoxia, i.e., you have them on a non-rebreather and they're still hypoxic, or you see on their blood gas that they're retaining carbon dioxide, then that's also an indication to intubate, but not necessarily something that maybe has to be done at that very moment. You probably have time with these patients. It's not a medical emergency to leave these patients on a non-rebreather while you try to kind of differentiate why they may be altered. All these other things are just kind of nuanced things, but I generally want you to remember just that the GCS of less than 8 doesn't necessarily extrapolate to intubate. It means that, all that data is coming from trauma, basically. Um, Usually with these patients, just a jaw thrust, stimulation, or manual bagging is enough. But if you feel the need to intubate them because of their GCS, just remember that the GCS is only really validated for trauma patients, okay? Intubation should be avoided, and we talked a little bit about this, but if the patient's breathing very heavily and they have a metabolic acidosis that's driving their metabolic or driving their tachypnea, it's because they're trying to get rid of carbon dioxide, and if you intubate them, you won't be able to match their minute ventilation. So their carbon dioxide will inevitably retain, and they'll be made more acidotic. This is really commonly seen in DKA. Asthma has its own list of problems when you intubate it, but you also want to make sure that these patients are resuscitated. If you don't resuscitate them before intubating them, things can go awry as well. Intubation is a very invasive procedure. So when you're talking about like specific treatments for altered mental status, I want broad strokes for this. So generally just I want you to remember to treat vital sign abnormalities. Like if patients have vital sign abnormalities, try to support their vital sign abnormalities, reassess what their vital signs are after an intervention, and try to come back to whether or not, their vital sign abnormality is persistent or if it's improved with, interventions. Okay. Excuse me. I also want you to support their airway as needed, but that does not always mean that you're going to intubate or that you're going to ventilate the patient. And then I want most people to understand that your job with these patients is to try to kind of figure out why. Why are they sick? And that basically comes down to a question of, do I need to support their metabolic status? Do I need to support their infectious status? If they have an AKI, why do they have an AKI? This is like the art of medicine at this point. There's no algorithm that can kind of clearly delineate why a patient is altered. You have to really kind of go into the deep cuts and try to ask yourself the questions after examining the patient, after doing serial exams or doing an initial exam and getting a history. Why are they not doing well? Um, and that's just kind of an important reassessment, an important assessment of the situation. Um, when you admit these patients, I want you to remember that we have something called delirium precautions in the United States. It basically just means that you're monitoring them, but that you're also normalizing sleep-wake patterns. Treat seizures if they're at play, normalize electrolytes, and make sure that you treat any underlying infection. This treatment component to it is not nearly as important. What I think you guys probably find more daunting about altered mental status is that it's an undifferentiated sick patient. And usually these patients are quite complicated. I want you to try to remember the negative and positive symptoms that can be associated with each underlying component. But make sure that you're talking to patients, you're obtaining collateral information, you're asking about past medical history. The most important part is to try to make sure that you're getting in a complete picture. Make a phone call if you have to make a phone call in terms of trying to get in additional information. I do this all the time. I do this every day, probably, at my job in the emergency department here in the States. Um, and I just want you to remember that, identifying the cause is essential for adequate treatment. And just give yourself a little bit of grace because altered mental status is complicated. It's hard to treat. If you don't have an answer, it can be stressful. So that's basically all I have. I want to open the floor. Dr. Clement had some things that he wanted to share. I don't know if you're still on, Clement. But if you guys have questions or concerns, you can feel free to ask them now. Um, and we can definitely open up conversations in terms of um, different causes for altered mental status and discuss them in their own lecture at some other point too, if you guys have specific questions or concerns about other things. Otherwise, we'll talk about infection in February.
Hello, Dan.
Hey, Clement, how are you?
I'm good. How are you?
Good. Do you
All
still want
right.
to talk about the case?
Oh, not really. I think the session took longer than we anticipated.
Okay. No
Probably
worries.
we can make some other time for it.
Sounds good. Okay.
Yeah.
Guys, have any questions or concerns before we wrap up? Thanks for
Personally,
Yeah,
I
go
don't
ahead.
have a question.
Okay.
Yeah.
Okay. Well, it's good to see you guys. I'm gonna send out some here, I'm gonna stop recording here for a second.